Not all coronary heart disease is the same. Some heart cases are complicated by factors such as numerous or high-risk blockages and other coexisting medical conditions. I'm Sharon Chang, your host.
And I'm Fernandez, your co-host. Now, today on our show, we have two doctors from CVSKL, Dato Dr. Hamdan Leman. He's a consultant cardiothoracic and congenital surgeon, and Dr. Fazir Omar, consultant cardiologist, who will be speaking on how to manage the risk of coronary heart disease. Welcome to the show, gentlemen.
It's a pleasure to be here. Thank you very much for inviting us.
Dr. Fazir, maybe you can share with us how prevalent and common is coronary heart disease and what do you see in your practice?
Hi, Sharon, thanks. Okay, let me share a screen for my slides as well. Okay, let's have a look at it. Okay. I'm going to talk about heart disease and how to manage the risk in heart disease. Well, before we start, I'm just going to show you a case of what we mean when we talk about heart disease and heart attack. This patient was brought collapsed. He collapsed in Kuala Lumpur and was brought by ambulance. And again, once he arrived, his heart stopped again in our A&E, and we had to shock and resuscitate him. So this is the cath lab. So we have to do a primary angioplasty where we bring him immediately to the cath lab. And this is this coronary artery on the right side, which is quite normal. On the left side, you can see that it's completely occluded, and that's the reason why he collapsed. So that's what we talk, or that's what we mean when we say somebody's got a heart attack. The blood flow just is interrupted, and there's no blood flow, and the heart is dying in a way. What we do in the primary angioplasty is that we put in a wire to the occluded artery, and we tend to suck out the thrombuster. So we use something to aspirate the blood clot. And then we do some ballooning to the artery, and that immediately restores blood flow. And we normally would implant. So when we say implanting a stent, this is what we do. We implant a coronary stent in the heart, and that immediately allows the resumption of blood flow back into the heart. So hopefully by doing this early enough, there is no damage to the heart. So that's where it's important to recognize a heart attack and seek treatment immediately. Again, the blood flow is restored. So oxygen, he's done very well. He was discharged and was followed up in clinic. He's doing very well. And also another patient as well who came in with 4 in the morning, and you can see when the heart is really bad, you can see that his lungs are full with fluids because the failure of your lungs as a heart. So, but he did very well as well, did primary angioplasty and doing very well in clinic. When we talk about the heart is really an engine that beats the moment we are born to the day we leave this world. And when we talk about blockages or arteriosclerosis, it's some form of narrowing that you have in your heart. So when we talk about heart attack, there's an immediate blockage. No blood flow means chest pains, means muscle death, and sometimes you have dangerous heart rhythm. If you survive the heart attack, and hopefully you have a normal heart, but if you don't, you might have a weak heart that might lead you to heart failure. So Malaysia, heart disease has always been a major cause of top killer for the last many years. And the striking part of it is that in Malaysia, our average heart attack is 58 years old, which is nearly 10 years younger than our most neighboring countries. So it happens earlier. We have seen a heart attack about 20 years old coming with heart attack. So it's not only for the 58 years old average age, you do see the very young ones coming in with heart attack as well.
Doctor, is that because of our diet and lifestyle reasons?
Yeah, because we are a champion in the region. We have the highest amount of rate of obesity in our region, the highest amount of diabetes. So that's the major problem is the lifestyle. I think we are blessed with very good food, and but I do see a trend nowadays. Especially in this CMCO that everyone's doing more exercising. My neighborhood, everyone is cycling and exercising. So I think we need to change our lifestyle and change our diet.
Sorry, Dr. Fazir. Yeah. Those are environmental factors. What about hereditary? So if I come from a family who has history of heart diseases, so how high is my risk factor?
That's a good question. So I think when we talk about cardiac risk or heart attack risk, you have things that you can change and there's things that you can't change. So of course, things that you can change is your diet, your lifestyle, your hypertension. You can measure it, diabetes, not smoking, and having a healthy lifestyle. Yes, I mean genetic plays an important role as well. So if you have a father, brother, sister having a premature heart disease, then your risk of heart disease is higher. So there are things that you can't change. I mean, genetic, as well as being male. So males are higher risk of heart attack. And also, as we grow older, the risk of heart attack is much higher.
Now, Dr. Fazir, also, is there a genetic predisposition? Because there is obviously an urban myth that Malays and Indians are obviously more prone to heart disease.
Yeah, so that's true. I think there are some genetic, it's not all, so we can't blame everything on genetics. But you're right. I mean, majority of the heart disease do occur in Malays and Indian. And I think most of it is genetic, but also lifestyle. Okay, and I mean, there are, of course, other genetic, like some patients, they have familial high cholesterol. So even though they're very young, they present with very high cholesterol levels. So there are part of it that is genetic, but there are also part of it that is lifestyle.
So Dr. Hamdan, maybe you share on this. Some people, I mean, it might not be genetic and it might not be environmental factors also. They might live a very healthy lifestyle, but they still develop coronary heart disease. Why is that so?
I mean, that's sometimes quite difficult. You look at the patient.
Is it due to stress? Does stress actually?
Yeah, we know that some of these could be the factors for patient without any comorbid factors, like mentioned by Dr. Fazir. Of course, we are looking at one is age. The other thing is sex, more male than female. Racial means genetic preponderance, and lifestyle is very important. Like, for example, difficult. Sometimes we look at a patient who are quite lean, non-smoking, exercising, but they still can have the diseases. So this is something like a outlier, but that's something that people need to be aware of. I mean, even though you are keeping a lefty lifestyle, your cholesterol might be higher than the one that is taking lamb shank every other week, that kind of thing.
But Dr. Hamdan, I want to ask you a little bit more about that, because among lots of corporate players, for example, in the last couple of years, there have been instances exactly of the profile that you mentioned. Exercise very well, they are not obese, so BMI is good, they regularly exercise, they eat well, no family history, yet overnight they basically develop a heart attack, drop dead, and die. Now, one of the studies that I've read talked about sleep being a big factor in these sort of cases. Could you elaborate on something like that?
Well, it's true. I mean, sometimes these things are unexpected. Sleep we are talking about is maybe related to stress. You have to have a good, healthy lifestyle. Basically, what we are trying to say is that you have to look at yourself, even though, because these are known as a silent killer. So you must look at yourself as your own risk profile. One is that if you are certain age, for example, 40 or 50 and above, so you must do some kind of screening program. For example, you must do your medical checkup. You need to look at your physique, whether your BMI is more than what it should be, and how the lifestyle that you lead. Are you a smoker? You drink alcohol? You sleep late? Those kind of things. Or you are in a very stressful environment. These are all the risk profile that can lead to heart diseases. And more so if you have other comorbid factor like hypertension, diabetes, dyslipidemia, high cholesterol. So when you have this, I think even though you are not having any symptom, because sometimes that symptom that people present as described by textbook is chest pain, pressing in nature, going up to the jaw, to the left of the arm. Well, this is in 60-70% of people. if you are diabetic, 20% of them, they don't have any symptoms. So don't mean that you are okay, asymptomatic that you are okay. So these are what we would like to do, is that look at your risk profile, how you live your life. If your BMI is high, your tummy circumference at the level of umbilicus more than 36 or something like that. So you have you have to take up cycling, maybe, for example.
Yes, a very healthy.
Yeah, Dr. Fazir, maybe you can share with us how many types of heart diseases are there, and are they all interrelated?
Yeah, I think, well, the commonest heart disease when we always discuss is the arteriosclerosis. So it's the narrowing of the artery. So that is the commonest heart disease when we discuss. But of course, there are many other types of heart disease. I mean, there are, so that when we talk about the narrowing, it's your coronary arteries. Then you have others like your electrical of your heart as well. So some patients, commonly females, they will present with palpitations or very fast heartbeats. So that one, normally, they have to come and we need to do some basic tests to check whether they have, irregular heartbeats. Others are like structural heart. So we have valves in the heart as well. So it's like your car engine, you have the valves and the motors are working. So we have valves, and the valve function, and some patients, their valve becomes a bit leaky or a bit narrowed. So typically and traditionally, they will go to Dato Hamdan for surgery for either an aortic valve or a mitral valve repair or replacement. But nowadays, there's also ways that we can do to repair certain patients via a more minimal approach by using either TAVIs or microclaves. And there are others. I think Dr. Hamdan is a well-known congenital heart surgeon. So there are also patients who are born with these conditions. So you can't blame on the lifestyle. They are born with certain conditions like a hole in the heart that they would need surgery for this. So there are various kinds of heart disease, but commonly when we mention, it's normally known as the narrowing of the heart, causing heart attacks.
Is it more common, heart diseases, common in female or males?
Well, if you look at our statistics, we have more males presenting with heart attacks. That doesn't mean that females are completely protected, because initially they are protected because the hormones are protective. But the moment they lose their hormonal cycle, they quickly catch up with male. And the problem is that sometimes female don't present your traditional, like what Dr. Hamdan was mentioning. I have a friend of mine who she thought she had a back pain and wanted to go for a massage because of thinking that it was a back pain. And when it got worse, and then when she started sweating and breathless, that they went to hospital and she had a heart attack. But can you imagine, the first port of call was going to a massage place because of a back pain. So sometimes they have back pains, and sometimes you have like gastric pains as well. So one of the patients was meant to go for a scope, an OGD scope, because of like gastric symptoms. But it felt a bit weird, and when we did the ECG and his blood markers, he actually had a minor heart attack. So traditionally, 70%, most of the time, they present with left-sided pain here on the chest, radiating to your arm and sometimes to your jaw. But there are also patients who present with just being fatigued, tired, back pain, gastric pain. One of our patients, his main complaint, Brian, was he used to cycle up the hill really fast. And now he couldn't cycle as fast as before. That was his only complaint. And he had a 99% blockage. So,
oh my goodness.
No kidding. He had a 99% blockage, and his only complaint was up that hill he went not as fast as he used to be able to.
So coming back to blockage, so I'm going to ask, maybe I pose this question to Dr. Hamdan. Now, Dr. Hamdan, when it comes to artery blockages, it's a choice between sometimes angioplasty or bypass surgery. Sometimes it's obvious, but sometimes maybe it's not. Could you sort of highlight this to the lay persons like us? What is the procedure? What are the alternatives and stuff like that?
Well, it depends on who the patient see first. Basically, I'm sure, this is a field that has been in controversies for so long, but this is not only local. it is internationally. This is because of the development of the care and the technological advancement in the care of patients with coronary artery diseases. You know that the problem of patients with coronary artery diseases is because of the blockages. And these blockages, if depends on how many arteries that are involved, how severe is the blockages, so the symptoms may vary. Basically, there's a stable and unstable kind of coronary artery disease. For example, for stable coronary artery disease, whereby you don't really have much symptoms, the options are basically you can opt for either optimal medical therapy, meaning just taking medicine, or when there are significant blockages, that's where the choice, either you are going for PCI, like what Dr. Fazir is the top PCI people in CVSKL, or you will go for surgery. And of course, the difference is that PCI, I mean, Fazir will talk about it more, is less invasive. And when
so a quicker recovery then as well.
Less invasive. When we talk about coronary artery disease, when you are treating coronary arteries with catheter-based intervention, it is less invasive. And when we want to do coronary bypass surgery, it's be more invasive, means we have to open up the chest and we have to use heart-lung emission sometimes. But well, coronary artery disease is one of the most studied cases over the world. We have thousands and thousands of data and documents. There are things that is best done by percutaneously, means through catheter base. And there are also things that is best done for surgery. So basically, one does not fit for all. That's why internationally now, because of this confusion to the patient, basically, because the patient don't know what is best for them.
Exactly. And then,
so,
Dr.
yeah,
Hamdan,
that's why it is recommended that in a heart center, especially in CVSKL, this is one of the idea of having CVSKL, is that to pool the cardiologists and the surgeons together, whereby any cases should be discussed among the cardiologist and the surgeon. And this decision is made custom made for the patient, what is best for them, depending on their age, the nature of comorbid factors, the number of vessels involved. So this would be, I think, the best for the patient. So maybe Fazir would like to elaborate on that. So I think heart team is important. Whatever the patient choose, I think is multifactorial. If they are in a place whereby surgery is less done, maybe more or catheter-based, they will choose for catheter-based intervention. It could be institutional or hospital factor, and also the way how if there's a presence of a heart team by the cardiologist and the surgeon discussing the case together and recommending what is the best for the patient, I think that would be the best.
Yeah. So if I may,
Dr. Fazir, maybe you can elaborate what Dr. Hamdan said, that you can elaborate more on that.
Sure. I think that is a fantastic question, first of all, that you asked. I think Dr. Hamdan, answered beautifully. I think, of course, there are certain hospitals, they might be limited by facilities and the availability of surgeons and all that. But in the center of excellence, I think you do need a heart team. And so it's very nice that Dr. Hamdan is just next door to my clinic, that we can always refer. And just to give you an example, we had a patient about a month ago, and he saw Dr. Hamdan. He didn't want surgery, quite bad vessel. And I think surgery for him may be the first choice, but he didn't want, so he went to us and we did the percutaneous minimal approach. I had a patient last week, and he just did the operation last week. He's gone home today. He had a severely bad vessel, all blockage, young guy, 49 years old, and he did not want surgery. He came to me and said, "Doctor, I want to do stenting." And I talked to Dr. Hamdan and said, "Look, this guy is really bad. I think he's got so many blockages." So I sent him next door, despite him not wanting to see a surgeon, and he agreed for surgery. When he came back, he said, "Yes, doctor, I will do the bypass." And I said, "Wow, it's so nice to have somebody next door. A patient can just come here, see next door, and can make a fully informed decision for the betterment for the patient.
Now, generally, and this is an open question to both of you. Obviously, medical technology has improved tremendously, and obviously for a specialty center like yourselves, you have experienced curve effects. You've done this, you do the same thing all the time, you know the variations. What are the risk and possible complications of having these operations, and generally, what is the success rate?
So I think I'll answer from my side is that I think like what Hamdan said, you have to tailor to the patient, to the customer. You can't treat every patient the same. So when you see a patient, and I feel like it's quite straightforward, then the risk is going to be very low. So I think we try to minimize the risk by having, so when you have all these options of surgery minimally, and you have to tailor made to the patient. And hopefully when we do this, the risk is very low. So I think you can't just brush aside, say, okay, everybody's going to go for stenting, everybody's going to go for bypass, because there are pros and cons in either procedures. I mean, so I think that if you tailor-made, and the surgery becomes quite low, so that's the whole point here. I think that's the whole point of having a heart team.
So if the patient is very elderly, so what do you recommend? Surgery, would surgery be out of the question?
Maybe I would answer that. I think basically, and also what Brian has said earlier on, what is the ultimate, because this is something that is very high at stake. Sometimes people don't understand that when you have coronary artery disease, it is affecting the heart. The decision that you make is a very, very heavy. Maybe we talk about it, heart team and whatnot, but it's just like giving execution order or something like that, So this is something that is very serious. Is it? One of them is people may don't understand that, but this is something, decision that has to be made, a very well informed decision, because it's very difficult for the patient or the family to understand the whole jargons of what is the advancement, what has been done, what is current, what is, those kind of things. So yes, this falls very much to our shoulder as a care provider to be, forthcoming in what is, due to giving the information. Well, the questions about what we call the 70 years old. I mean, age is certainly is a consideration. For example, like what is the development in the cardiology now that they can do aortic valve replacement, that has always been the domain or the territory of surgeons, because if the patient is suffering from requiring aortic valve replacement at a very such advanced age, the risk should be higher. But after saying that, there are also cases that undergoing cardiac surgery, even at the 70s or even 80s, if need be. I mean, if they are okay, we can optimize them. I mean, this is why now it's very what we call conscience-wise in our mind is quite clear, because we have the cardiologist, we have the surgeon, we come and we tell what is best for you. After all, that's what this is all about. That's what matters. What is best for the patient. Yeah.
Can they lead a normal life after that?
Yeah. I mean, just for your information, I mean, of course, heart surgery is a very major surgery. I mean, no doubt about it. I mean, 25 years ago when I started, and what it is now is totally different. We have undergone a lot of refinement and advancement. The risk of heart surgery for coronary, what we quote is on mortality of 1%. I mean, there's a 99%. We cannot say 100% because we are not God.
Oh,
we say 99%.
Yes.
1%. But of course, when you have any other comorbid, heart failure, kidney failure, for example, a lung failure, or your extreme, but it's around that 2-3% maybe, for example. So this is not too bad.
Fantastic.
Recovery is quick. We always send patients after cardiac surgery maybe around 5 to 7 days, and they can resume their normal function after a month. Actually, yeah. So it is.
Okay, so
of course,
that's quick.
yeah, sure.
No, so final question, gentlemen, and maybe perhaps we'll start with Dr. Hamdan first. Any last words on this matter in terms of what advice you would give people in their 40s and 50s in particular in terms of looking after their hearts and watching out that they don't develop heart disease?
Well, like what I've said before, even you are at 40 or 50, this is the time when you have to reflect, look at yourself. I've survived all this while. How long more will I go? So basically, what I'm trying to say, you look at you have any family member with a coronary artery disease, or you look at yourself, how's your health? You have any medical issues, hypertension, diabetes, cholesterol, your lifestyle, smokers, and if you are in those categories, BMI, things like that. So you must consider yourself to go for a screening program, which is basically doing blood tests and some exercise stress tests. Maybe there are a lot of other things can be done, calcium scoring, equivalent. So this is what I want them to do. And thirdly is that if you have somehow doubts or some condition of requiring, like for example, coronary artery disease, please do go to a place that is, I don't want to sound like we are bragging, whereby they are the pool of expertise in that place that can discuss, evaluate, and look at your case and give you a thorough deliberation on what is best for the patient. That would be my point to the listeners. Thank you very much.
Thank you, Dr. Hamdan. And how about you, Dr. Fazir?
Yeah.
Words of wisdom.
I mean, words of wisdom. Well, I mean, nowadays, I think, we do need to take ownership of our own health. I mean, so I think number one, screening is important because you never know what's your risk factor. I mean, we all may look so healthy and cycle and run and swim, but you really do not know our true profile until you do a proper checkup. And then the other thing, I think it's ownership as well. I think, prevention and ownership, because one of my patients, he's so diabetic and he's got a heart disease. And I said, your real problem now is that you really have to change your lifestyle. I mean, so they need to start taking ownership of their own health. I mean, we can advise, we can treat it, we can put a stent or a bypass graft or a new valve. But really, I hope that all Malaysians would start. I mean, and it is. I mean, I see so many people now cycling and running on the street. So take ownership of your health. Look after yourself better, so that we hopefully become a healthier nation as a whole.
Dr. Hamdan and Dr. Fazir, thank you so much for taking the time to be on our show. We have been speaking to Dato Dr. Hamdan Leman, consultant cardiothoracic and congenital surgeon, and Dr. Al-Fazil Omar, consultant cardiologist, both from CBS KL. I'm Sharon Chang.
And I'm Brian Fernandez. This video will be on our Facebook and LinkedIn sites, as well as our website, www.biztech.asia. Please check out our website for business and technology conversations via articles, videos, and podcasts, and subscribe or like our Facebook and LinkedIn pages.